Welcome to the Australian Prescriber Podcast. Australian Prescriber, independent, peer-reviewed and free. Hepatitis C has been a substantial burden on our healthcare system and in our community for such a long period of time, as it remains for much of the world, particularly with related hepatocellular carcinoma in mind. In recent years, however, something incredible has happened. Directly acting antiviral therapy has meant that the possibility of a widespread cure could become relatively quick and easy for the right price. In March 2016, Australia embarked on a transformative mission to cure hepatitis C in as many people as possible with a view to eradication. So, 5 years later, where are we at? I'm David Liu, your host for today, and I'm very glad to be speaking to someone who can speak to this issue unlike anyone else. Professor Gregory Dorr, an infectious diseases physician from St Vincent, Sydney, who's the program head of the Viral Hepatitis Clinical Research Program at the Kirby Institute at UNSW, and amongst other things, a world leader in hepatitis C elimination strategies. He's written on this subject for Australian Prescriber, and I'm very glad to welcome him to the podcast today. Greg, thanks for joining us.
Thanks very much, David.
Perhaps you can illustrate to us why this is such an important issue. Why is eradication beneficial for patients, and why is that the right strategy to go about trying to do things?
I suppose just a little bit of background that sort of led into the program commencing in 2016. And I mean, I've been involved clinically in hepatitis C for 20 years, and sort of going back to the late 1990s, I mean, people were treated for hepatitis C, relatively small numbers, but with interferon injections, very, very difficult to get through treatment. The success rate was really quite poor. With interferon alone, it was really only 10% cure rate with 6 or 12 months of therapy. Then we added in ribavirin as a sort of second agent. That improved things somewhat to sort of around 40%, but still a real struggle, like 6 to 12 months of a lot of side effects, a lot of fatigue, some psychological side effects, and it really was a tough road for individual patients. And we were treating in Australia maybe 2,000 to 3,000 patients a year on the back of that sort of therapy. So to have such a transformative opportunity where you go from that situation to a situation where you've got a highly curative therapy to 95% or above with 2 or 3 months of oral therapy with minimal side effects is really incredibly remarkable to have that sort of opportunity to cure hepatitis C, which for many of them was causing significant symptoms, was causing considerable sort of concern around what the future may hold in terms of advanced liver disease complications. So yeah, it was a remarkable time when it sort of arrived. It's been an incredible journey sort of since, and really grateful that Australia's had this opportunity.
Why wouldn't we just treat this on demand? Why would we go about trying to actually eradicate hepatitis C? I mean, I think that might seem obvious to some, but I think there's a real cost differential between these two approaches potentially.
Sure. I think it's important to look at things at the individual and the population level. And I'm fortunate, I suppose, being a clinician and also a public health academic, that I do look at things from those different perspectives. So as an individual patient, I mean, the key is to cure their hepatitis C. If they're at risk of ongoing exposure, reinfection, to try and limit that risk, and then if they're reinfected, to offer them treatment. So at the individual level, it's relatively straightforward. So you inform patients of the benefits of this new therapy and the prospects of cure. There's not many people that say no. So that's a pretty simple sort of equation, a very unusual equation, really, in the context of medicine. Here's an opportunity to cure a chronic infectious disease you may have had for decades with this sort of 2 or 3 months, very, very well tolerated therapy. That side of things, I think, pretty straightforward. So then the population level strategy is, okay, if we can cure people at individual level and we can provide the broad access points, we can actually turn this epidemic around. So an epidemic of hepatitis C that was sort of increasing in terms of numbers infected, increasing in terms of advanced liver disease, so liver failure, liver cancer and liver-related death numbers prior to 2016. So a real public health concern. But with this new therapy, we absolutely had the opportunity to turn things around and to potentially break the back of the epidemic. So to really reduce transmission of hepatitis C in the community to a point where in conjunction with our harm reduction strategies that we have for people who inject drugs, adding this treatment on top of that provides amazing sort of prevention sort of capacity. So reducing individual sort of risk of liver disease at the population level, having an impact to the epidemic in two ways: reducing the number of infections that are being transmitted, and at the sort of the far end, reducing the liver disease burden that arises from those infections.
I think that there's a lot of talk at the moment in the context of COVID and the stage that we're at and the pandemic about what eradication means and how sustainable that is. Were you always confident that hepatitis C eradication was something that might be possible in Australia? Is this, and I know we're clearly not there yet, but it's an exciting prospect.
So just a little on terminology. I don't tend to use eradication. Eradication infectious diseases is a very, very small list. Smallpox is the only one that sort of sits on that list. So elimination is a somewhat lower bar. So elimination in the context of infectious diseases is actually getting infection or disease down to zero levels in a particular population or geographical setting. That's even pretty tough in the setting of hepatitis C. And in fact, the WHO, in defining their elimination goals, have not talked about getting it down to zero in different areas. They've talked about reducing the number of new infections by 90%. They've talked about reducing the numbers of liver-related deaths by 2/3 as the goals that they've set for sort of 2030. So I don't think with the treatments that we have and with the harm reduction strategies that we have, that we can stop infection completely. I think that's a huge, huge ask. But I think we can get transmission levels down to a point where there's not large numbers of people becoming infected every year. And it's a very, very, very manageable infection then because of the curative nature of these treatments.
Absolutely. How did starting on this journey become possible in Australia 5 years ago?
Yeah, I think there are some key elements that Australia has provided, or in terms of the foundation. So I think Australia's always been pretty strong on the prevention side. So that's the first thing to say. So we had implementation of needle and syringe programs since the early 90s, broadly available across the country, funded by the federal government, really pivotal to prevent HIV epidemic amongst people who inject drugs, and then also having a contribution in terms of prevention of hepatitis C. So that's really important. We also had pretty decent sort of drug treatment programs in terms of methadone and buprenorphine available. So those elements of harm reduction were a key sort of foundation. We also then had very good data. So Australia, I think, does epidemiological data collection pretty well, and we do some really good modelling. So we had a good understanding of what our epidemic was, the size of the epidemic, who was infected, how things were sort of moving along in terms of escalating sort of numbers, particularly advanced liver disease. So that helped sort of frame what was required in terms of the numbers, and that was really important, I think, for the government to sort of look at funding a major sort of therapeutic intervention through the PBS. And then we had, I think, absolutely important skills within the government to negotiate on price. So I remember back in 2014, 2015, a lot of discussion, including the pharmaceutical industry advisory boards and so forth, and about how we were going to deal with a high cost item, which initially was sort of $70,000, $80,000 per course in the United States, and a high demand given the large number of people that would be keen to get treated. And there was a lot of discussion that we should be focusing on people with advanced liver disease, with cirrhosis, and that should be the target for the initial sort of few years of the program, which had been the case in other countries around the world. Because of high costs, they'd said, well, let's just sort of focus on those that need it the most. But Australia had a different approach, and I think absolutely the right approach. They felt that, okay, we're keen to make a big investment in hepatitis C treatments. We've got $1 billion or more. Rather than paying $40,000 or $50,000 a course, which might enable people with advanced disease to get treated, let's bring the price down per patient to say $10,000 to $15,000 per patient, and then we can treat a much, much larger number of people across the disease sort of spectrum. In terms of the drug companies, they get a really decent sort of return on their investment. In terms of individual patients, they have an opportunity to have access to these amazing new therapies. And in terms of the government, they have some security around the budget impact. So they also built in a sort of a cap in terms of the annual expenditure that could be paid to the drug companies. So those sort of three elements, I think, were really crucial in developing a world-leading program, and many countries around the world sort of looked at what we had rolled out in 2016 and thought, oh, why can't we do this?
And so this Netflix model for drug funding, is this something now that has been more broadly adopted in other countries, like you've mentioned?
Absolutely. It's been adopted by individual sort of countries. It's also been adopted by states within the United States. So there's been a range of different arrangements that have sort of flown, I think, or come from where Australia sort of led. And I think the key to all of this is, as I said, everyone's a winner. I mean, in terms of larger number of patients sort of treated, drug companies getting return on their investment, and it's a really good sort of model to go forward with. It's just common sense public health, and I think Australia has done that side of things very well. The other important component of that model was if we develop this arrangement, then we need as many people as possible to get involved in the treatment side. So the fact that they enabled non-specialists, so primary care practitioners, other physicians, to prescribe direct-acting antiviral therapies from day one, basically, was essential to the success of the Australian sort of model. Now, in those initial months, GPs needed to get some approval from the infectious diseases or gastroenterology specialists in terms of what they're prescribing. So that was an important mentoring and sort of oversight component. But now, as I'm sure everyone's aware, in fact, the majority of people are treated by primary care physicians, and the model has gone incredibly well. And despite some specialists in those early sort of days thinking the sky was going to fall in because GPs were prescribing DA therapy, it certainly hasn't fallen in, and I think Australia's benefited enormously from that diversity.
Absolutely. This goes to show the power of enabling our primary care and workforce in trying to tackle on this type of public health problem. How has it gone? 5 years later now, how are we tracking? Has it gone better or worse than we've thought?
We treated 36,000 in 2016. In fact, we treated 36,000 in 10 months of 2016, from March to December. So incredible sort of start to the program. Not surprisingly, the numbers have come down since then. But in the sort of 5 years of the program, we've treated around about 100,000 people. And that looks like it's at least half of the sort of people with chronic sort of hepatitis C. So that's really impressive. I mean, there are some concerns that the numbers being treated per year have come down in recent sort of years, and there's a lot more work to be done. But if we sit back and look at the first 5 years of the program, amazing sort of success in terms of numbers treated, amazing success in terms of turning around escalating rates of liver cancer and liver failure and liver-related deaths, and absolutely early indications that numbers of new infections that are being acquired in Australia is also trending down. So all the things that you would want to achieve over that sort of 5-year period, I think.
Absolutely. Well, with that kind of early success, I think it almost sets up expectation even higher. The people who thought this might not be possible at all now eyeing off elimination as a real possibility. I mean, do you think that the path from here is straightforward and smooth? Or
no, look, it's not straightforward, and on some levels it'll get tougher. And that's sort of natural in the sense that you think the early adopters, people coming forward for treatment, may have had less sort of issues in terms of other health problems, other socio-economic issues that they had to deal with. So it will get tougher. We've done incredibly well in terms of uptake amongst people who inject drugs, but we need to continue to do that. We've reduced the amount of infection in that population from around about half of people who inject drugs having active Hep C infection down to under 20%. So we're sitting at around about 18%. So well over a sort of halving of that. But there's still this important sort of pool there to engage with, and we need to be more innovative in terms of how we do that. So a few things that we're trying to do. One is to provide opportunities where people interface. So, for example, if someone who develops an injection-related infection is hospitalised for cellulitis or endocarditis or osteomyelitis, we're trying to sort of develop projects that provide rapid screening and treatment initiation during that hospitalisation. Another thing we're trying to do is more rapid screening in the prison setting, particularly in remand prison, where people can come and go within sort of weeks or a few months rather than a longer incarceration period. So to screen people on entry initiate the therapy straight up. And with the only sort of 2 months required for one of the regimens, you can get that completed for the vast majority within that sort of time frame. And also through needle syringe programs, that more sort of innovative approach where we screen people and get them onto treatment with peer support. So we're looking at those sort of models of how to sort of make it a bit easier to reach the harder to reach sort of populations. There still needs to be some work done in sort of what you might call more general sort of primary care sort of practices and services, because there still are people out there who haven't taken the opportunity to come forward for therapy. So I think we need a lot of education around that, both at the sort of patient level and also at the practitioner sort of level.
You've written quite extensively about trying to target people who are otherwise vulnerable in those kind of situations. You've written in the New England Journal about this and quite broadly. And then yet as well, there's this other cohort of people who may not necessarily meet those kind of conventional definitions, but who may have had long-standing infection. Do you think that we're going to be able to address both of these cohorts similarly? Do you think that which one do you think we're really going to have the better success in going forward, and what can we do about that?
Yeah, look, I think they're two arms of what's required sort of going forward. Look, they're clearly different populations, even though they're somewhat sort of overlapping. I think for the group of people who are injected drugs or people that have acquired their infection overseas, for example, migrated to Australia, and there's a significant number of those people, we do need some specific campaigns. So when we've looked at the treatment uptake through what we call our data linkage projects, we have found some gaps. And those gaps include people who've been born overseas, having a somewhat lower treatment uptake, people that have experienced homelessness, and starting to emerge a little bit Indigenous Australians as well. So there's some key sort of strategies around those different sort of populations. I think some targeted education campaigns are really important for the overseas born and for the broader sort of population. For the homelessness experienced population and for Indigenous, we again need some very sort of specific and targeted sort of programs that provide those sort of access points. I try and be an optimist, and I'm pretty sort of optimistic sort of going forward that as long as we continue to innovate, as long as we continue to build a diversity and number of potential access points for treatment, then I think we'll do okay.
And I guess there's still always the issue of primary prevention as well, in amongst talking about the challenges to elimination at the beginning. That's still an issue which we need to be conscious about, given that there's still quite a large number of people out there with hepatitis C.
Yeah, look, the primary prevention obviously is essential going forward. I'm not concerned as others have been about things like reinfection. I've always expected some reinfection cases to come through. I mean, you treat people who become reinfected, they're very easy to treat. They haven't got resistant virus, they've got a new sort of wild type virus. So it's not a complex sort of management scenario. Treatments work very well. And some people need to be retreated a second sort of time. So that's not a concern for me. And the government sort of arrangement allowed for that to happen, which was essential. And once we reduce the pool of active infection, continue to drive that downwards, in fact, the risk of reinfection comes down. So we'll see less and less cases of reinfection because of that smaller pool of active infection. But maintenance of that sort of foundation of primary prevention is essential, not just for hepatitis C, but HIV, and just to have that interface with people who inject drugs are clearly a highly marginalised population.
Mm. Do you think that we've learnt lessons from this that we could apply elsewhere? Because, this really objectively is an international success story. Should we be taking what we've done here and trying to apply some of it in other challenges in healthcare?
Look, I think the lessons are to be ambitious, to look at sort of public health in the context of striving for really important sort of targets. Now, look, you might not reach them, and I'm pretty confident still that we'll reach the WHO sort of targets. But the really key thing is to have the ambition to do that. And look, to segue a little bit to COVID, I've found some of the ambition around COVID to be not as impressive in terms of our sort of vaccination strategy. Obviously, I think in public health, it's great to sort of set goals and targets and really try and strive for them. I mean, the one area in all of this I'm still sort of concerned about, I think we need to do a lot of work on, is Indigenous Australia. We are seeing some increasing numbers of infections, particularly in younger Aboriginal people, and I think we need to do a lot more there as a key sort of population group sort of going forward. But getting back to the original sort of question about what lessons can we take, I mean, the other lesson is that a partnership approach, and we've seen this in HIV prior to hepatitis C, it really is the way to go. So, the involvement of community, clinical, academic, government, and other stakeholder groups getting together and developing strategy and sort of working together on a lot of this. That's a model that's not unique to hepatitis C, but is a model that I see more and more actually in public health. I review sort of grants for NHMRC, and one of the key sort of elements that they're really looking for now is what they call end user involvement, so involvement of the affected community. And that's something that we've done for a long time in HIV and hepatitis C, and it's a very natural sort of partnership that we've had. And I think that's a little bit foreign to some other areas of clinical medicine. So you learn a lot from partnerships with the affected community, and it's a very much a two-way sort of interaction, and it's a really valuable component of the overall strategy.
Well, that's a really nice message to hammer home at the end. Thank you so much for all the work that you and your colleagues have done so far. Good luck with the progress in the future, and thanks for joining us on the podcast.
A pleasure, David. And a final sort of message to prescribers out there who may not have climbed on board the Hep C elimination wagon, so to speak. Get involved. It's a great area of clinical medicine, incredibly empowering, and very fortunate to have this opportunity.
Absolutely. Time to be part of the success story. Thank you so much.
Thanks, David.
The views of the guests and the hosts on this podcast are their own and may not represent Australian Prescriber. I'm David Liu, and thanks for joining us on the Australian Prescriber podcast.